one of the mistakes that people make when it comes to the fascial lines, especially from a clinical standpoint and application standpoint, we just jump straight to the muscles and we neglect everything else. And remember, when we talk about the fascial lines, the importance of the fascial lines it's not just the mechanical actions that the muscles perform, it's in how we gather that sensory information. It's how this line contributes its sensory information to the nervous system. And when we think about that, when we think about the areas where there's the highest density of nerve endings, it's not in the muscle belly. It's where that muscle, that tendon, that periosteum all come together. So if all we focus on are the muscle bellies, all you're going to be able to consider and influence is the mechanical side of things. If we ignore all the structures on the right side of that picture, you're missing the largest component of sensory input that the fascial line provides. From a manual standpoint, one of the most impactful areas just in general that you can target and address are those junctions where the periosteum and the tendons come together. That tendo-periosteal junction. Those areas we can create and manipulate influence to the nervous system much easier in those areas than we can by going just after the muscle belly. So don't fall into that trap of just thinking superficial backline is just these muscles. Yeah, it is, but you're missing the largest contribution to the nervous system if you ignore the other areas, which is why we've really started to break those out. And we see the soft tissue, we see the other areas on the right side. So from a muscle standpoint, start at the feet, work our way up. Flexor hallucis brevis, abductor hallucis, flexor digitorum brevis, all of our short toe flexors. Come up into the gastroc, semimembranosus, semitendinosus, long head of the biceps. Short head of the biceps is not included in this line. And then we have all the muscles of the erector group, and then the suboccipitals. We've already talked a little bit about the suboccipitals. There's a total of 8, 4 on each side. From a bony standpoint, again, starting at the feet, working our way up. We start out at the plantar surface of the phalanges, which, again, sensory input from the plantar surface of the phalanges, that's a very direct interaction, very, very direct communication with the surface that we're walking on. So if we go back to the homunculus, the sensory homunculus, the soles of the feet provide a lot of sensory information. So this is one that, again, the plantar surface, this is one that if we ignore this, we ignore a lot of the sensory information that we can be getting from this line. Calcaneus acts as a fulcrum. That becomes important when we start talking about the clinical implications of this. Femoral condyles up to the ischial tuberosity, sacrum, the occipital ridge, and then I think it's also important with the superficial backline to understand your superficial backline starts right here. It starts right at your eyebrows, wraps around the entire back of your head. So that's that supraorbital ridge. So if we just look at these bony landmarks, how many times do we deal with ischial tuberosity issues? Quite a bit. How many times do we deal with hamstring issues? Quite a bit. So this line is very influential when we think of some of those issues that are hard to deal with. I think I've talked about it in this class before. I think at some point in every athletic trainer's career, we have that time period where it's like, holy crap, it's a hamstring issue. Let's just hope we get to the end of the season and it goes away when the season's over. Let's just try to limp this through because it's a frustrating thing for us to deal with. It's typically a frustrating thing for us to deal with because when we deal with hamstring issues, we deal with hamstrings. And we're missing everything else that is influencing and affecting that hamstring. You can't fix a hamstring problem by targeting the hamstring. If you do, you get what we always got, which is hoping that we get to the end of the season. Now, that's not saying that the hamstring's not the problem, and that the hamstring isn't where they're suffering or noticing the pain or the problems with, but the solution lies in actually moving away from that hamstring. Here recently, we've gotten wild and crazy, and it's not just the hamstring, but let's also consider the ischial tuberosity. It's a step in the right direction, but it's a very small step because we have all these other structures to consider as well when we're talking about hamstring issues. Other structures in the line: plantar fascia, Achilles, the sacrotuberous ligament. You don't remember where the sacrotuberous ligament is? It runs from the ischial tuberosity up to the lateral border of the sacrum. And then the epicranial fascia, so the fascia on the back and the top of the skull. And again, if we just look at these structures, if we come here and look from a muscular standpoint, we see clinically a lot of hamstring issues. We deal a lot with hamstring issues. We deal a lot with ischial tuberosity issues. Anytime you have a hamstring, you're going to have the ischial tuberosities. Occipital ridge. Anybody with neck pain, anybody with headaches, anybody with shoulder stuff, that's a consideration. We don't often think of it, but that needs to be a consideration. When we look at the other tissues in the line, plantar fasciitis. Again, something that comes up quite often, and if all we consider is the plantar fascia, that becomes another one of those frustrating issues that we just hope goes away, because our ability to fix it isn't that great, because all we typically consider is the plantar fascia. And again, just like the hamstring, there might be stuff going on in the plantar fascia, but the solution doesn't only lie in the plantar fascia. Achilles. This is the year of the Achilles tear in the NFL. His name Rodgers went out first game of the season, and now Kirk Cousins is out. So we're starting to, we see that quite often in our world. Luckily, the procedure to repair the Achilles tears have gotten quite a bit better here recently, but we see this quite often. Even if we're not dealing with an Achilles tear, we oftentimes see tight Achilles, tight gastroc, tight soleus. I'm the prime example. You can literally stand on the angle board for 10 minutes a day for years and still have a dorsiflexion restriction. Just stretching out the Achilles, if you can, just stretching out the gastroc, the soleus, that alone is not going to do anything for a dorsiflexion restriction, no matter how long we do it. Lumbosacral fascia in the low back issues, we're going to see this and have to interact with this quite often. Unfortunately, that's something that we don't often spend time working on. But when we get to the lab, we'll talk about that as well. So from a postural standpoint, the entire function of the superficial back line is to not give in to gravity, to basically hold us in upright extension. At the knee, superficial back line kind of has a supportive role when it comes to assisting the ACL and the PCL. How the hamstring tendons and how the gastroc tendons interlock at the knee, especially when the knee's in extension, provides a lot of anterior-posterior support to that knee. Now, as you move away from extension, that locking mechanism kind of backs down just a little bit. But that's also not the only locking mechanism when we're in full knee extension. That screw home mechanism is there as well. So in knee extension, it's a very stable position. But that also ties into the function of this line of maintaining an upright posture, not giving any gravity. From a movement standpoint, this line is all about extension. No matter how we describe it, this line is about extension, except for the knees. Knees are flexion. So the exception to this rule, or the exception to this function, is the knee, or are the knees, where we go into flexion. Because this line, because the overall postural function of this line is to support the body against extension, support the body against gravity, and hold us upright all day, when we look at the fiber types of these muscles, they're the type 1 fibers, more endurance-based, because they need to be on at a very low level for an extended period of time, so that we can maintain upright stance against gravity over the course of the day. So at the end of the day, you've been on your feet the whole day. The reason that your low back's tight, lumbosacral fascia, all the muscles of the superficial backline have been on all day, providing tension to that area. We're going to notice that. Tightness in the hamstrings at the end of the day. We've had a low level of tension in the muscles all day long. But that's what they're designed to do, and that's how they're designed to function. And so physiologically, they're geared to work very well with that function. It is one of our cardinal lines, the two cardinal lines being the superficial back line, superficial front line. In coordination with the superficial front line, they basically, superficial front line, superficial back line work together to keep us vertical all day long and to maintain our postural integrity and our postural alignment pretty much at the knees, the ankles, the pelvis, the trunk, and the neck. Don't just think that there's one superficial back line. There's a superficial back line on the left side, and there's a superficial back line on the right side. They're not connected. They're in very close proximity to each other, but they are not connected. Why that's important, you can have an issue on one side and not the other. And as soon as we start to run into just an issue on the left superficial back line, now what that does, because of their orientation, we can create a little bit of rotation, a rotary component to a lot of the things that we're seeing. One of the things that we see quite often is when somebody gets into a deadlift position, they have their pelvis rotated this way. As soon as we see this weird pelvic rotatey type thing in the bottom of a deadlift, we know that we're looking at a left to right issue, or we know that we have to consider a left-right issue within the superficial back line, superficial front line. We know there's not symmetry between those lines. And then the other thing, again, we talked about this one when we talked about the suboccipitals. There's a very high tie-in with our visual system at the superficial back line. And again, that goes back to where our eyes go, the head goes, where the head goes, the body follows. So the superficial back line needs to be able to react and respond very quickly to vision to get our head in the right position so that we can then orient the body to follow along with that. We look at this list of issues. We see a lot of this stuff all the time. Dorsiflexion restrictions, hyperextension of the knee, recurvatum of the knee, short hamstrings, tight hamstrings, whatever you want to call it. We could throw weak hamstrings in there as well. Anterior pelvic tilt, sacral nutation, and anterior tilt of the sacrum, lumbar lordosis, hyperextension of the cervical spine, anterior shifting of the skull on C1, so moving the head forward. So both of those, cervical hyperextension, anterior shift of the occipital on C1, both lead to a forward head position. And then again, because of that visual tie-in, we can have an impaired ocular motor reflex, which again is just the ability of us to have appropriate movement tied in with our vision. It's easy to look at this list and think, okay, if I have a dorsiflexion restriction, it's a superficial backline issue. Remember though, if we're talking about a superficial backline issue, there has to be a corresponding superficial frontline issue. Because the only reason these issues develop is if there's an imbalance or an inability of those lines to work together efficiently and communicate together efficiently at that joint. And so when that happens, what we see is a limited dorsiflexion problem, or dorsiflexion restriction, or hyperextension problem. So we're not going to get just the lordosis problem just by having issues within the superficial back line. There has to be additional changes in the superficial front line to go along with that. When we talk about the foot and the ankle, two big things that we see here: issues within the plantar fascia and issues with dorsiflexion. With the dorsiflexion, when we talked about the calcaneus as a fulcrum a second ago, oftentimes what we think when it comes to the common perception when it comes to a dorsiflexion restriction is we just have tight gastroc and tight soleus. All the posterior structures are tight, and that tightness is what's preventing us from actually moving into dorsiflexion. How often, though, do we run into a dorsiflexion restriction? And one of the complaints that the patient has with their dorsiflexion restriction is a pinch in the front of the ankle. That's usually when patients start to complain about it, because people don't complain about a dorsiflexion restriction because that's the dorsiflexion that they know. People don't come to us saying, I don't think my ankle moves the way that it's supposed to. People come to us when they start noticing a pinch in the front of the ankle. Every time I get in the bottom of a squat, I get a pinch in the ankle. Every time I run, or if I put my foot down aggressively, I get a pinch in the front of the ankle. Or every time, it's now progressed to the point that every time I jump and land, I'm getting a pinch in the front of the ankle. So by the time patients come to see us, they're coming to see us for the pain that's associated with the movement, not the limited movement. So what often happens with a dorsiflexion issue, it presents as anterior ankle pain. Why does a dorsiflexion issue present as anterior ankle pain? Why does it happen? If you don't understand why it happens, you're not going to be able to fix it. How does a tight gastroc, a tight soleus, create ankle pain on the front of the ankle? Better yet, let's walk this back a step. Where is that anterior ankle pain coming from? What structure is causing the pain in the front of the ankle? It's not a tight gastroc. So what's causing the actual pain when I hit end-range dorsiflexion? What's causing that pinch in the front of my ankle? What was it? Could be the anterior tibialis, because the anterior tibialis is having to work. But if we get anterior tibialis pain, it's not likely going to be that sharp, stabby type pain that's focused in the front of the ankle. It'll present a little bit differently to us. We can get that, but oftentimes, if we're getting that sharp, stabby pain in the ankle, it's not going to present that way to us. Often, when we run into that sharp, stabby pain, it's when the talus butts up against the anterior tibia. So tibia, look at tibia, talus. So when I'm dorsiflexion, as soon as my talus butts up against that tibia, bone on bone always hurts. There's no meniscus in the ankle. There's no shock absorbers in the ankle. So when we go bone on bone, it is going to be painful. You get that sharp, stabby pain. That comes from the talus. The talus, though, now notice what I just said. There's no meniscus in the ankle because we don't need meniscus in the ankle. Because as long as the talus is where the talus is supposed to be, we have enough space, we have nice chondral surfaces, there's no pain. But what changes to where now all of a sudden when I go to normal end-range dorsiflexion, normal for me, I'm getting a pain because now my talus is butting up against that. And how does that relate to a dorsiflexion restriction? Have any of you guys ever shot a bow and arrow? You pull the bow back, the arrow goes this way. What happens when you let go of the string? The arrow takes off. Well, if we think about this now as a bow and arrow, the Achilles plantar fascia, the Achilles and the plantar fascia become the string. The calcaneus becomes the arrow. When this gets tight, it drives that calcaneus forward. Well, what's the calcaneus sit right underneath? The talus. So when the calcaneus is driven forward, the talus is driven forward. So now the whole foot shifts forward on the tibia. And we're not talking a whole lot. But when that tibia, when that talus shifts forward a little bit, and I dorsiflex, now we get bone on bone. Not like we have here where there's space. We run into bone on bone. So that anterior impingement that we get in the ankle, yes, it is due to a tight gastroc tights. It is due to tightness in the gastroc and the Achilles and down in the plantar fascia, but we get that impingement because we're driving everything anterior. We're driving everything forward. We do that long enough, what do you think happens to the joint capsule? It shortens up to this new position, it adapts to that. So that's one of the reasons why, because by the time, we have to remember, by the time somebody develops this isn't an acute issue. This is something that the body adapts to over time. So, and that's where we have to understand that to fix it, because by the time somebody is adapted and this is happening, That capsule is started to tighten up and lock down. That talus is now forward. A forward talus is that new normal position for that ankle. If all I do is stretch, if I spend all my time stretching the Achilles, doing soft tissue work back here, doing soft tissue work on the bottom of the foot, again, we're doing the right things. But what we're not doing is addressing that capsule, which is adapted over time. So the capsule is good. We're going to create tension here. And when we create that tension, we create an instability because now this talus is supposed to be forward. Now there's no tension here. So what do? We bring tension and we tighten the stuff back up. We actually continue to propagate the problem, and if anything, we make it worse. So we do this, but we also have to address that capsular adaptation over time, which means we have to mix in some joint movement. It means we have to mix in and do some actual soft tissue work at the capsular level. And there's ways that you can do that, some that are more successful than others, but we do have to address the joint capsule with this. But then also with this, we have to explore the rest of the superficial backline. Where else is this extra tension coming from that's feeding into the tension in the gastroc and the soleus? Because if I come to you guys for an anterior pinch of my ankle, and you guys do all the right things, you do all the things I just outlined. You work on the gastroc, the soleus, you do soft tissue to the Achilles to create some space, you work on the bottom of my foot, you do some joint mobs, you dry needle the capsule, you do all the things I just said, all the correct things I just said. And then I leave and I have a little bit of an anterior shift. What's that doing to the entire superficial backline? It's bringing tension because now if there's not tension here and my weight's out in front of me, I fall forward. Remember the function of the superficial backline, resist gravity. So you can do all the right things, but if we don't address the rest of the backline, you're doing all the right things for that 30 minutes, that hour that you have with them, but then you send them out into the world and they spend the rest of the day like this, it's going to come back immediately. So we have to consider everything else in that superficial backline. And that's probably the most important thing when it comes to the fascial lines. Yes, we've correctly identified an anterior impingement. We have to address the capsule. We have to address the local structures, but we also have to consider the rest of the fascial line. Because the easiest way to think about the fascial lines, tension anywhere in the line is going to create tension everywhere in the line to some degree because of how the lines are interconnected with each other. So if you do all the right things to take care of from the knee down, that's wonderful. But if my thoracolumbar fascia, my erectors are on all day because I'm lacking hip extension and I'm here, this tension is going to carry down into the gastroc soleus. It's going to carry down into the plantar fascia. It's going to continue to drive that talus forward. So we have to expand and look outside of this after we've addressed this, or while we're addressing it. When we're talking about plantar fascia, we see heel spurs develop. If heel spurs have developed, we know that we're talking, again, heel spurs, they don't develop overnight. They take time to develop. Usually we have an acute situation where I started to feel the pain on this day, or when I was running on this day, this is when it started to hurt, which can be kind of confusing because now in our mind we set that as that starting point. But we have to understand, if I'm having a conversation about heel spurs, if that's the starting point, this started 8 weeks ago, because it takes about 8 weeks for us to get that bony formation at minimum to where it's going to be problematic. So we have to consider everything going on with this. What ends up happening is you have a very similar situation to what causes that calcaneus to be driven forward, but now the weak area is where that calcaneus and that plantar fascia are interacting with each other. You get this constant anterior tension, and the body does what the body does. The calcaneus does what the calcaneus does. It's got stress. How does bone address stress? It lays down more bone to get stronger. Bone, based off of, if you guys remember Davis's law, Wolff's law. Bone's going to align along the lines of force. If the force is constantly pulling this way, we're going to get spurring of that calcaneus, and that becomes painful. If you go see a foot specialist, if you go see an orthopedist, as soon as they see the heel spurs, hey, we're just going to go in. It's a simple procedure, small incision. We're going to shave that down. It works. Guess what happens in about 8 to 16 weeks? It comes back because we shaved off the body's mechanism to mitigate the stress. And so then the body starts back over again. But now what happened is that didn't work the first time. We have to bring even more to the table. So we're going to get more spurring off of that. Now, if somebody has a heel spur, am I saying no, they shouldn't have surgery to remove that? I'm not saying that at all. But if we're going to go in and we're going to remove this, we have to understand this is the result of something. We have to also address that something. Because some people, this will become very problematic and it will need to be removed. But if we don't address the tension that's leading to this, it's only going to come back. So we will need to go back and address those forces so that then the calcaneus isn't having to lay down more bony tissue there. Otherwise, it's going to come right back. At the knee, when we look at this interconnectedness between the gastroc tendons and then the hamstring tendons, they overlap at the back of the knee. When the knee is in full extension, there's bringing quite a bit of tension to the table. There's a lot of anterior posterior stability that this interconnectedness brings to the table. As we move out of extension, as we move into flexion, this starts to go away. It's not as stable. But as we move the knee out of extension and we move into flexion, now because of these connections, we can actually have some degree of rotation of the tibia. When we look at the medial side of the knee, when we look at the lateral side of the knee, you have the long head of the biceps femoris. Remember, the short head's not a part of this line. Long head of the biceps femoris comes down and inserts onto the fibular head. When the knee's flexed, if that lateral hamstring, long head of the biceps shortens, it's going to create tibial external rotation. You can create an external rotation. When we consider the medial side, when we flex the knee, we can create an internal rotation moment. Now, if we look at these two, long head attaches to the fibular head, the semimembranosus attaches to the tibial plateau, semitendinosus comes all the way down and attaches just medial to the anterior, or to the tibial tuberosity. So it wraps all the way around into the pes anserine. Because of this connection, we can exert a lot more internal rotation into the knee than we can external rotation. We can create a lot more tibial rotation because of that mechanical attachment and how far anterior it sits. And as we flex the knee, we can create a significant amount of tibial internal rotation. Now, that being said, the ability to rotate the tibia only happens when the knee is flexed. If the knee is extended and as the knee gets closer to extension, the ability to internally rotate the tibia by itself goes away. As we get to extension, the only way that we can internally and externally, we can create a little bit of a moment down at the ankle. We can create just a little bit of tibial internal external rotation, but a majority of that's coming from the hip. It's internal external rotation of the leg. As we flex the knee, now we can create a lot more internal external rotation. Pelvis. Sacrotuberous ligament. And this is without this ligament, this fascial line would end at the ischial tuberosity because there's no muscular connection from the hamstrings into the next muscle group, the erectors, which again is important from a consideration standpoint of we have to consider these other non-muscular structures that also contribute to this line from a force transmission standpoint, but then also from a sensory input standpoint as well. So Sacrotuberous ligament goes from ischial tuberosity up into the sacrum, and then it actually blends in. It has some superficial fibers that blend into the erector muscles, the sacrolumbar fascia, to continue for that continuation to occur. Why is that important? Oh, I think I have a. I'll talk about that in another slide or two. We undervalue the sacrum. When was the last time you guys treated the sacrum? When was the last time you did anything for the sacrum? Maybe some sacral mobs. How much does the sacrum move? Millimeters. So sacral mobs do have their place, and they do have their time, and they do create change. But we're talking about sacral mobs on a joint that doesn't mob. The SI joint is not a mobile joint. You don't want the SI joint to be a mobile joint. If you have an SI joint that is a mobile joint, you have a problem with your SI joint. Let's use the knee, for example. Post-op knee. How often do we do patellar mobs? It should be every post-op knee. Because we need that patella to move a lot. We need it to move a lot medial-laterally. It's got to move superiorly if we want to be able to flex the knee. So we have to have a patella that is highly mobile in order for us to get full knee flexion extension. The sacrum, and how I learned this is we do sacral mobs to mobilize the sacrum to get the sacrum to move. That's wonderful. But the most the most that we're going to get any kind of movement out of this SI joint is millimeters. And some people will say, and have support for this, we don't even get millimeters of movement with that joint. Because the SI joint is not a joint that's designed to move. When you look at its orientation, when you look at the joint surfaces, it's not a smooth joint, it's actually an interlocking joint, so that it's very stable. And the reason it is because of where it is. All of the weight of the body passes through the SI joints. It's got to be able to support that. You don't want a shoulder joint doing that. And when I say a shoulder joint, a joint like the shoulder to do that. So all of the components of the knee, all the components of the shoulder that make them highly mobile joints because of the large degree range of motion that we have to have, none of that exists in the SI joint. In fact, the exact opposite exists in the SI joint because we don't want it to move. But the clinical intervention that we're often taught are sacral mobs. There are a time and a place for those. But what other techniques do you guys know other than sacral mobs to address the sacrum? Right, that becomes the only thing we know. The sacrum, because of, and this is a great example of how we try to address things from a mechanical standpoint. We need things to move, but we need things to not move. And we try to teach the ankle to move because we have dorsiflexion restrictions, and then we try to teach the shoulder to not move because we have hypermobile shoulders. The entire world of an athletic trainer typically is through the lens of what do I need to get to move and what do I need to stop from moving. And that's fine from a mechanical standpoint. I'm not saying that doesn't have its place. Where the problem lies is if that's our only approach, if that's our only consideration. Because the sacrum is a great example of, we don't have a whole lot of motion of the sacrum. The only interventions that we know are mobilization interventions. And again, we're not going to get a lot of movement out of that even if we do that well. The biggest contribution of the sacrum has to do with what it does from a sensory standpoint, what it does from an input standpoint. We have the sacrotuberous ligament, which transmits force. Sacrotuberous ligament blends into the lateral border of the sacrum. The lateral border of the sacrum has a significant amount of influence on the autonomic nervous system. Wait a second, it's not even close to the brain. How does it have any influence over the autonomic nervous system? Well, let's flip this around for a second. take a look at the front side of that sacrum. Because when we think about the sacrum, this is what we think about, right? But let's look at the other side. The entire lumbar plexus comes out of, literally comes out of the sacrum. I mean, it's passing through the foramen of the sacrum. If there are issues, what do you think happens when you're doing an anterior mob of that SI joint? You've got some pretty big nerve roots that pass right on the front of that. Do we really want to be mobbing that? And again, there is a time and a place for that. But should that be our default, is my question. And I'm going to say that shouldn't be our default. The sacrum has a significant tie-in to the central nervous system because of its proximity to those very large nerve roots. Sciatic issues, sciatic pain. We often, oh, it's a sciatic nerve. Okay, that's wonderful. But what about the sacrum? Let's not just think about the sciatic nerve. Let's think about where does the sciatic nerve come from. It originates out of the sacrum. Now, it doesn't originate out of the sacrum. It leaves the nerve roots pass through the sacrum. Why is that important? You guys are all familiar with the brachial plexus, right? As an undergrad, we have to learn the brachial plexus. At some point, they probably made you learn the named nerves that branch off of that, correct? And we have to learn the importance. When you're learning about the brachial plexus, how often do we tie in the importance of the scalenes? If there's pressure from the scalenes on the brachial plexus, it's going to lead to distal neurological symptoms, correct? Why don't we get that same kind of attention for the lumbar plexus? We don't. And then when we run into situations like sciatica or issues with the sciatic nerve, we completely abandon our thought process and we just go straight for that sciatic nerve. Not always a sciatic nerve issue. So when we treat and address the sacrum, we can exert a lot of control over what's going on from those nerve roots down into the leg, but then also the input that those nerve roots are providing up into the central nervous system, which can have an effect on autonomic control of the body. So that sacral plexus is extremely important. So then the question, how do we treat the sacrum? When we go to the lab, we'll go over some manual ways to treat the sacrum, but then also there are some more advanced ways to treat the sacrum with dry needling that can exert a huge influence on what's going on in this area. We won't do that in class, but I'll make you guys aware of it. From a ischial tuberosity standpoint, when we think of the ischial tuberosity, hamstrings attached there. Essentially, this is where the difference between the sitting posture and seated come into play. Sitting from a neurodevelopmental standpoint and seated are not the same thing. What you guys are doing right now is not a part of the neurodevelopmental sequence. You guys are seated in a chair. Seated in a chair is a bad thing if you spend too much time doing it. There are actual books, like thick books. Literally, I think one of the ones I have at home is about 1.5 inches, 2 inches thick, that talks about how sitting in chairs, all the negative problems that it creates, and it's correct. One of the things that happens, especially in these lovely chairs that you guys are sitting in, hard chairs that don't have any cushioning on them, you guys are essentially compressing all of this tissue into the ischial tuberosity. You're pancaking that ischial tuberosity. You're pancaking that sciatic nerve. You are compressing that all day long. Yes, sitting in a chair is a bad thing if you do it for too long, and we think about all the negative ramifications that happen and flow from that from a postural standpoint, but let's just think about it from a tissue standpoint. If you spend 8 hours compressing your hamstring tendons, the hamstring mass up into that ischial tuberosity, that sciatic nerve up into that ischial tuberosity, what do you think is going to happen to that tissue? Well, first off, just from that sheer pressure alone, what's happening to the blood flow to that area? It's impaired because of force. The vertical forces of those tissue close off the capillary beds. You don't get blood flow to the issue. You've created an ischemic situation. What happens when you have prolonged ischemic situations? Nothing good from a cellular standpoint. On the extreme of things, you have cellular death, you have tissue death. Why is this important? When was the last time you dealt with a hamstring issue? In a high school or college age student that is required to sit for 6 to 8 hours a day. College student, well, they might not sit that long. Okay, they're only in classes for 2 hours a day, but then they have team meetings. How long do team meetings take? Like half a day. And they sit in chairs like this. So even in that instance, we have hamstring issues with athletes that spend all day sitting, compressing those tissues. We stretch the hamstrings. What do we do to increase blood flow to the area? Because if we don't address the physiology of it first, we can't outstretch it. We're dealing with tissue that's not healthy. Now, the easy solutions will just tell them not to sit. Yeah, that's fine, but you can't really tell a third grader to go to school and have a stand-up desk. It's not going to happen. They're still going to sit. You can't tell a college kid that they have to stand up in class. Though some of them might be able to because you have that freedom. Just worked out perfectly. Worked out perfect. But once you start talking college age, you do have that freedom to do that. But we still have to do something to improve blood flow. And if we don't do anything to improve blood flow, you're going to continue to have problems because you have problems at a cellular level. And we can't outstretch a cellular level problem. We have to work on blood flow. Blood flow restriction is a great way to do this. Wait, blood flow restriction, that's the exact opposite. Yeah, you put the band on, you compress it, you can do whatever you want to with it. That's going to include the blood flow, but guess what happens? Have any of you guys done BFR stuff before? The greatest feeling in the world is when you take that off. And what's it feel like? I don't know how to describe it, but yes, we all know what that feels like. What is that? It's a return of blood flow. So the thing that we need to realize about the body is anytime we restrict something, core temperature is a great example. Why do people recommend taking a hot shower if you want to go to bed and want to help you fall asleep? We think that's because it's so warm and it makes us tired. You're right. But it's so warm, when you increase your core temperature, that actually wakes you up. But as soon as you get out of that hot shower or that hot bath, core temperature has risen. Oh crap, it's outside of our normal value. We need to pull this back down. What do? We cool the core off. When the core temperature cools, that's when we fall asleep. Well, what ends up happening is core temperature goes too high. We need to now self-regulate. Let's cool the core temperature down. We don't cool it down just enough to get back into normal. We cool it down below normal because we have an overreaction so that we can return to a baseline. Same thing with BFR. We have the occlusion. We stop the blood flow. We take it off. We get a reperfusion, an increase in perfusion to that area that lasts for a little bit after we remove that because of how the body over-adjusts. So it's a great way to increase blood flow to the area. Dry needling also is another way that we can increase blood flow to the area. Any of our superficial work can increase blood flow. The problem is with our hands-on stuff, we just typically aren't able to get deep enough to actually get to those deep tissues at the ischial tuberosities. The only two ways to effectively do that are with BFR and dry needling that I'm aware of. Even ultrasound, the depth of penetration doesn't quite get far enough for that. Up in the erectors, or up in the head, majority of the weight of the head actually sits in front of the fulcrum, so the point of rotation. So the superficial back line is having to spend quite a bit of force and effort to maintain our head in a level position. Now, as our head, you guys have all heard it or seen it somewhere, as the head moves forward, the head becomes heavier because of engineering and stuff. That's true. So the more forward the head is, the more tension there's going to be in the superficial back line. But even if we have a perfectly neutral spine and everything is perfectly lined up, the superficial back line still does have to maintain a level of tension because there's more weight on the front side of the skull than the back side, even in the best case scenario. But if you see that person that has a forward head or a rounding of the upper spine, it's magnified even more, and we know that there's going to be a superficial backline issue. Because we talk about the erectors, the erector spinae group, and there's a lot of those individual muscles there, but it's that entire group. And we're going to see that transition down into the hamstrings, down to the gastroc as well. Suboccipitals, we talked about this before. The rectus capitis, posterior minor and major, and then the obliquus capitis, superior and inferior. The nice thing is anytime you see a minor, you're going to see a major. If you see a superior, you're going to see an inferior. You have 4 on each side. They attach from the occipital ridge down to either C1 or C2. 3 of the 4 attach into the occipital ridge. You have 2 that attach down to C2. This is the deepest portion of the superficial back line. The important thing to understand about the suboccipitals, this is the functional centerpiece of the superficial back line because of the tie-in with vision. Like we talked about before, as soon as I look up, the entire tone of the superficial back line is more extension. As soon as I look down, the entire tone of the superficial back line is to allow more flexion to take place. Because where the eyes go, the head follows. Where the head goes, the body follows. So where the eyes are, adjust the tone of the suboccipitals. The tone of the suboccipitals are going to influence the tone of the rest of the superficial back line. So as the eyes are up, we're bringing more tone to the table in the back line. As the eyes are down, we're bringing less tone to the fascia, to the entire line. We talked about the rest of that before. From a postural standpoint, the superficial back line begins to develop in prone. Everything we talked about in prone, the whole reason for prone, what we're trying to do in prone, all goes back to, or all ties into developing the entire superficial back line. Any questions about the superficial back line? Perfect, superficial front line. Everything we talked about, think about the exact opposite side of it. It's now all on the front of the body. Same thing, left side of the body, the muscles. Right side of the picture are the non-muscular tissues. There's a couple, vastus lateralis, vastus medialis. They're informally a part of the line. The rectus femoris is the only formal part of the quad that actually is part of the superficial front line. Mm-hmm.
So when talking about like the left and the right, when we talk about like medial knee pain, mm-hmm. and then they can have like a bicep issue, mm-hmm. it's always going to be on the same side.
Not always. It depends on the fascial line that is. It depends on where the fascial line issue is. Because if it's the same side, if left medial knee pain, I find a trigger point in my left biceps, I make this go away. And I make this go away and my knee pain goes away. We know that that's an ipsilateral functional line issue because that's the connection that connects biceps through the arm line into the lat goes into the glute goes into sartorius, and it wraps around, and that's our connection. If we're going opposite side, now that's a spiral line issue because the spiral line is what connects right arm down here. The big question is, how do we know which one it is? And once we've talked about all the lines, that'll be easier to figure that out. Vastus lateralis, vastus medialis get lumped into it unofficially, but the rectus femoris is the only one that meets all the criteria to be included. But since the quadriceps typically function as a group, they're included as well. Sternalis, not everybody has a sternalis. Were you guys taught about the sternalis muscle in anatomy class? Basically, it's a little bitty strip of muscle that runs along the lateral border of the sternum on each side. It's absent. It's a lot like, what's the muscle? one of your forearm muscles. There's a forearm muscle, I don't remember what it is, that some people don't have. Can't think of the name of it. A lot like the plantaris in the ankle or in the back of the knee. Some people don't actually have a sternalis, but even without that, there is the sternocondral fascia that continues to line up that way if you don't have a sternalis. From a muscular standpoint, all of our extensors, the short toe extensors, the long toe extensors, hallucis digitorum, longus and brevis, anterior tibialis, the quads, rectus abdominis, up into the sternalis, and then the sternocleidomastoid on each side. Somebody has tight calves. Somebody has shin splints. Well, let's just stay with tight calves. Somebody has tight calves. One of the common things that we need to focus on is strengthening the anterior tibialis. Correct? Seen that? Heard that a little bit? Let's think about this for a second. Which one of those? Let's not consider the medial side of the gastroc. Let's just compare apples to apples. Let's look at the lateral side of the gastroc. So you have a lateral gastroc compared to the anterior tibialis. Which one is bringing more muscle mass to the table? Gastroc. Which one is designed with a fiber angle that's designed to generate force? Meaning you have some pinnation of the fibers into a long tendon, create a lot of force. That's the gastroc. Versus the anterior tibialis where the fibers run the length of the muscle. How on God's green earth is a little bitty anterior tibialis going to offset even the lateral gastroc? It's not going to. But then there's the side of it, okay, you're right, can't argue that. You know, if I'm getting in a tug of war battle, I'm going to put all my money on the lateral gastroc 100% of the time because it's going to win 100% of the time. But Brandon, we do this and it makes somebody's knee feel better. Okay, can't argue that. Can't say that it doesn't. Where does that come from? It comes from the entire fascial line. As I'm doing stuff in one muscle, the rest of the fascial line is adjusting to that. We're seeing fascial line changes. So even though from a pure physiological standpoint, and there's, oh, some of the videos, some of the screenshots off of the Instagram I showed you guys, a professional therapist showed me this exercise and now my knee pain is 100% gone. I mean, just, you don't, on my feed, must be getting that all the time. The algorithm shows it up every single day. They have this little thing now, the tib bar, you know, you put it on your ankle and you do all this. It's like straight up 1947 again, because it's not an original device. The first one came out by Weider Barbell in 1947, but we just found it again. Strength of the anterior tibialis, and it's going to fix all your issues in the world. How big is the friggin' anterior tibialis? If it's a giant anterior tibialis, it's that diameter. And I'm guessing most anterior tibialises aren't that big. But again, it works. And it works because the people that are selling the stuff are completely spot on with what we need to do, but their logic is correct, but the answer doesn't come from the anterior tibialis. It comes from what we're doing to balance that line. So we see changes in the line. Specifically, we see better input from the line, not because we have a strong anterior tibialis. Because even if we double the size of your anterior tibialis, it's still going to be a quarter the size of your lateral gastroc. So it's not from a mechanical standpoint that we see these changes. It's from a neurological standpoint within the fascial line that we actually see these changes. From a bony standpoint, I don't know why for this time I started up at the head, but we have the lambdoidal suture, the mastoid process down into the sternum. Fifth rib, why just the fifth rib? Because that's where we see the rectus abdominis come into play. Pubic tubercle, the anterior inferior iliac spine, so the AIIS. The patella, which acts as a fulcrum, the tibial tuberosity, the entire crest of the tibia down into the dorsal surface of the phalanges. Other tissues, there's not as many here. We have the fascia of the scalp, the sternocondral fascia, and then the patellar tendon that goes along with Function of the superficial front line is to offset and balance the superficial back line. From a postural standpoint, again, it's helping us support gravity, especially those areas of the body that sit anterior of midline, which ends up being the pubis, the rib cage, and the face. Everything else is either on midline or behind midline. Maintains extension of the knee. And then this last one, the startle reflex. Whereas the muscles of the superficial back line were type 1 fibers for endurance, the muscles of the superficial front line, when you look at them, they're predominantly the type 2 fibers. High force, high power output because of this startle reflex. And so when we say startle reflex, that's when you scare somebody, they typically move into some degree of flexion to protect the viscera, to protect the vital organs. So we do that by going into that fetal position or some type of fetal position. So that has to happen quickly. It has to be a very quick reaction, quick response. So the fiber types of the muscles in the superficial front line support that and allow that to take place. From a movement standpoint, again, the exact opposite of the superficial back line. This is all about flexion. It's all about flexion except for the knees, where we extend the knees, dorsiflex the ankles. The rest of the line is all about flexion. It is one of our cardinal lines. You have a left superficial front line, a right superficial front line. And again, it has to work in coordination with the superficial front line to mediate all the flexion and extension of all the joints involved. Large list of issues that we have here. Anything and everything that involves the anterior knee, hyperextension rector bottom of the knee, the dreaded rib flare, where we see the little riblets poke way out. I don't know if that's the official name, but that's what I call them, the little riblets, so they stick way out here. Anterior shifting of midline, that person that's just kind of leaning into the wind, the whole Michael Jackson dance thing. Then the last one on here, breathing restrictions. If we have somebody that has, difficulty being able to diaphragmatically breathe, it can be tied into problems within this fascial line. We look at the knee. How often every day are you dealing with knee issues? Pick some kind of knee issues. Anterior knee pain, jumper's knee, tibial tuberosity, apophysitis, the dreaded Osgood Schlatters, any patellar tracking issues. It's like a typical day that makes up about 50% of it, dealing with knee stuff. Knee stuff that's not actually inside the knee. We're actually doing extensor mechanism issues. I think it's important to understand that the patella acts as a fulcrum. The whole reason that we have a patella is so that we have a little bit more of a mechanical advantage of the knee, so that we can increase forces without having to have a giant, an even bigger amount, a larger amount of muscle mass in the quads. The fulcrum allows the quad tissue that we have to be more efficient because it moves the soft tissue a little bit further away from that center of axis, so it gives it more mechanical advantage over that. The patella is completely encompassed. It is a sesamoid bone. It sits inside that continuation of the quad tendon down into the patellar tendon. Some people call it the patellar ligament. That's completely wrong. It's 100% wrong because a ligament connects bone to bone. The patella sits inside this tissue. The tendon from the quad that attaches down to the tibial tuberosity, that's one continuity of tissue with a patella that sits inside of it. It's not tibia, fibular head, and a ligament that connects those two. It's a bone that's sitting inside a tendon. So this is a tendon, not a ligament. It has completely different mechanical properties. And that is one thing that drives me nuts. But Brandon, if we look at it from a traditional anatomy view, this tissue only connects patella to tibial tuberosity, so it meets the definition of a ligament. Correct, if you just live in a cadaver world. But if you live in a real people world, that's not the case. So we have to understand that if you have a patellar tendon issue, you have a quad issue, you have a tibia issue, you have a superficial frontline issue. And again, with this, we often deal with extensor mechanism injuries and issues if, once again, if all you're doing is addressing the knee, you're not going to fix the problem. You might make it feel better short term, but you're not going to fix the problem because this isn't a knee problem. We see the issues develop at the knee because of the tissue, because of how sensitive these tissues are, and this becomes the weak link. And we start to see tissue breaking down. And it has to do with the tension that the upper part of the superficial front line is generating towards the pelvis and what's being generated down towards the foot. We see all of the issues of the knee that aren't acute issues of the knee are issues in how the body is mitigating that excess tension in that area. Tibial tuberosity issues, Osgood Slaughters. Why do we develop Osgood Slaughters? We're just laying down bones. What does that tell us? There's tension in the area and the bone's trying to do what the bone does, and the bone creates more bone. So we deal with Osgood Slaughters issues, and Osgood Slaughters is a heel spurring of the knee. If we don't address the rest of the line, you're not going to fix that. And Osgood Slaughters is a long-term outcome of tibial tuberosity apophysitis, where you're opening up of that growth plate and tensioning across that growth plate. And the body does what the body does, lays down calcium, it becomes painful. By the time we get that bony predominance or that bony prominence there, that's going to be quite painful. If we have that removed and we don't address the tension, it's the exact same discussion that we had about heel spurs. From a surgical standpoint, they do this procedure called if somebody has a patellar tracking issue, Fulkerson's procedure, they'll take the tibial tuberosity, they'll detach the tibial tuberosity, and they'll move it slightly medially. Change the line of pull with that. And guess what happens with that? If somebody has a Fulkerson's procedure, the odds of having a good outcome are very, very poor. The only shot you have at fixing that is if, from a therapy standpoint on the back end, we start to address everything else. More often than not, though, it goes right back to that knee. All of the chondromalacia stuff on the backside of the patella is from compression. I just got done saying everything that we see at the knee is a tension issue, except for this is the exception. Because of the tension at the knee, it's going to pull that patella into the front of that femur, and you can get chondromalacia. So it's still a tension issue, but we're seeing a problem because of the compression that we're creating. Rib flare, the person that has the little riblets that stick way out. Basically, we see the rib flare, but what we don't see is what happens, what that does to the line of pull of the rectus, and what has to happen in the spine. We oftentimes see the giant rounding of the thoracic spine, but we don't appreciate what's going on in the lumbar spine or at the pelvis. And once again, if all we do is address the thoracic spine and not address the lumbar spine, not address the pelvis, not address the rest of the two fascial lines, we're not going to be very successful in fixing this. The lambdoidal suture basically is the suture between the occipital bone and the two parietal bones. The line, and why this is important is this is where superficial backline doesn't have this. The superficial front line does. The superficial front line, the left superficial front line and the right superficial front line are actually connected to each other through that lambdoidal suture. So the line of pull that happens, the line of tension in that right superficial back line comes up, it follows along that fascial connection through the lambdoidal suture, and it connects to the other side. So when you have tension on the right side, superficial front line, tension on the left side, superficial front line, because of all of that, it tends to pull that head forward. Which then contributes to that forward head position. This is also an area that we can treat and address. And if somebody has headaches, a lot of head neck issues, that's a very important area that we can address. The asterion has nothing to do with heel spurs. I don't know why that's there. If you develop a heel spur because of the asterion, you have a problem. The asterion, I talked about that one. The asterion is actually where the occipital bone, the parietal bone, the temporal bone all come together. So if you find your ear find the mastoid process. So the mastoid process is going to be right here. You just kind of go up and add a little bit of an angle. You'll find a small indentation right there. That's where your asterion is. Why is that important? Sternocleidomastoid, even though in this picture it looks like there's a nice clean line of end of the fascia, that's not what happens. It actually blends up in there. It's a very, you can, from a headache standpoint, especially somebody with a forward head, this spot, you can get a lot of benefit from treating that spot. The thing to keep in mind when it comes to, well, first off, any questions about superficial front line? Thing to keep in mind, we have to have that symbiotic relationship between the superficial back line and superficial front line. You look at that list of conditions that go along with the superficial back line, you look at that list of conditions that go along with the superficial front line, and what those lists are, those lists just represent an imbalance between the two fascial lines. Too much tension in one line, not enough tension in the other. We can also run into a left and right, front line, left and right, back line issue. And if we get that, we can create some rotational components to our movement as well. Some of those on the list, the anterior shift, the forward head, the breathing, everything else on here. The heel spurs, the Osgood Schlotters, those are all long-term adaptations that we see in the balance between these two lines. This is that cousin on your mom's side of the family that you don't get along with, that when you go to Christmas or Thanksgiving dinner, you have to sit in the same room with, and you just find a way to get along with them. Feels kind of, I mean, you guys follow the NBA? No, you need to. Russell Westbrook plays for the Clippers. Been there for a little over a year now, around a year now. Before he was with the Clippers, played with the Wizards. Before he was with the Wizards, he was with the Rockets. When he was with the Rockets, he played with James Harden. They didn't get along. Russell Westbrook wanted to trade. Before that, they played together in Oklahoma City. Had they stayed together in Oklahoma City would have at least one, if not two, maybe 3 championship titles by now. But they couldn't get along, and they had to go their separate ways. Why do I tell you all that? Sports Center posted a video of when James Harden just got traded to the Clippers, and he's now back with Russell Westbrook. And so somebody on their phone filmed when James Harden walked into the locker room of the Clippers. And James Harden walks in the locker room, Westbrook's over there, and the title that goes along with this video is this awkward moment. And so you see James Harden walk in, and he looks up, and he sees Westbrook, and Westbrook says a couple things. He's like, just make sure you stay on that side of the room. And like that's actually what the camera caught. I was like, awkward situation. When we have awkward situations between the superficial front line and superficial back line, we get these long-term adaptations. This is just how we learn to get by through the situations. We have to work together. We have to be in the same room together. This is what we're going to do to get by. When we look at our short-term conditions, these are the things that happen right now. These are the acute responses that over time will contribute to this. So we see the spurring of the heels, we see the tibial tuberosity, avulsion. We can have these. You can have a tibial tuberosity avulsion that's an actual acute issue. You can have an AIIS avulsion that's actually an acute issue. But a lot of the times, these tend to be things that start to develop over time, and this is our first indicator that there's something going on. Why I say that? When we see these, this is the first indicator that we're working towards a long-term problem. If we don't appropriately address these issues, this is what we're going to get to deal with. And this list of things to deal with, they're hard to deal with. And we get frustrated. Where did this come from? We don't know what happened. We had the indicators. We just didn't recognize that we have our short-term adaptations, that if we don't affect and address the entire line, we're going to get this. I don't know why I skipped this. Postural tie-in to the superficial front line is supine. Again, supine's a posture of flexion. Superficial front line is all about flexion, except for knee extension and dorsiflexion. So we start to develop the foundation of this line down in supine.